For those of you who don't know, I'm Tom Robinson. You actually elected me as Secretary-Treasurer of the medical staff somewhere along the line. So that's why I'm here today. Dr. Doyle has been trying to get together a series of things, and I know that I was not exactly aware of everything, and in our little world, we're not aware of what really goes on from the medical staff structure, here at the hospital, what our responsibilities are. So today, we're just going to try to go over and give you a little bit, hopefully, clearer idea of the medical staff structure, how we're supposed to govern ourselves, and what our responsibilities here are. So, did you have anything to say before we start?
Yeah, I'll set the context. The context for why this is important, and why Tom, why the medical staff leadership want to do this. First, this is one in a series of ongoing seminars, lunch and learns, dinner meetings, some of which will be repeated throughout the year. Just because we're doing medical staff governance now doesn't mean that we won't do this again in January for folks who have an interest in it, because we think it's very important that for us to be engaged, to have an active medical staff, that we're informed of this. Brian Lesh wants to do one of these seminars around quality. We're going to have conflict resolution. We're going to look at interpersonal communication. Just the various skills and knowledge and skills that we need to be effective in our roles as medical staff leaders. And when we started this back in May at the kickoff, one of the themes that comes up around leadership isn't necessarily about being in the boardroom. Physicians and leaders, and physician leadership isn't about, running a medical staff or leading a large multi-specialty practice. Leadership is getting a patient to take their metformin. That takes leadership. Influencing behavior. How do we influence the behavior of a patient? How do we influence the behavior of an organization? All the way across the spectrum, and at various levels, each of us has a comfort or at that, or a desire to do that, or a skill at that, and so it's across that spectrum that this is developed. The other part of it, that's added into this seminar that many of you know, but some don't, that every morning at 9 o'clock, the hospital huddles for about 15 to 30 minutes on safety. Every unit leader, division director, administrator gathers in this room or a smaller one when this isn't available, and we address safety concerns that have come up in the past 24 hours and anticipate those coming forward as a way of promoting quality and safety in the hospital. That staff's invited to that, and this is also an opportunity to say, come to that meeting. Michelle can help us. We have a plan as part of the seminar that also counts towards CMEs to attend those. You attend a certain number and register as part of the CME offered with this seminar that's going on throughout the year, just so you know. So there's CME for this, but coming to the safety rounds also as part of this seminar, get some of that CME out there. It gets you involved and see how the hospital, with its various leaders, works to address safety. Context for now medical staff governance. Okay, Tom has said that folks need to know. We think it's important from a structural standpoint, but in a very acute time, CMS is coming to visit. They're coming to pay us, we're with the government, visit. And Ann sent out a note a few weeks ago, probably a couple months ago now, telling the organization about that, but I'll review with that, with you what the letter said, was that the Department of Health in New York State works with CMS and does visits on behalf of CMS, as well as on Department of Health, and they'll do that in response to concerns, complaints, issues, follow-up, any reason Department of Health wants to come in. And twice early in the year, back in January and in March, Department of Health came in because of concerns expressed to them about one of our programs. That program was looked at. Clinically, there were no issues. The patient care, the care the patient received was fine. So the questions then arose about how we report on that quality. Okay, how do we know that that was a quality program? What's the data? How does the board know? What governance structures exist that say that the data that informs decisions for the hospital, the governing board, is data that's relevant and important? and we could not consistently show that we were complying with that condition of participation. Okay? And so this takes on some sense of greater relevance when we start talking about governance, because there could be a surveyor in the building some 6 to 3 months from now asking, talk to me about how quality is reported to the board. And it doesn't do as well if we have physicians that say, board, what do you mean by the board? Okay? So, so that's some of this as well. So that's some of the, the interest and urgency around this, and from an educational standpoint. So, may I go on?
Yes.
So on our first slide, just go to this next one. This is what the law says. And so we talk about CMS, Center of Medicaid and Medicaid Services, which establishes conditions of participation for those folks who would like to receive and will take care of patients who are Medicare, and they're the largest payer in the country, Medicare is. This is what it says we have to have. And the emphasis was added. Tom and I added the emphasis on the slide. It's not actually bolded in the law. We thought we'd do that to highlight that it says we have to have an organized medical staff. And that organized medical staff, and I love this line, is responsible for the quality of health care in the organization. And that's us. Okay? There's no caveats on that. That's not responsible for quality provided you get good data. Or, you're responsible for quality provided the quality department is helping you out. Or responsible for quality given that you have adequate call coverage. There's no conditions on that. It just says you, the medical staff, are responsible for quality. Wow. So, that's what they say.
And ask questions, and if whatever is presented, just interject as you will, raise your hand.
So, okay. So on the next one, so this is, then when they put out these interpretive, and this is some of our discussion, and then this is going to be a discussion as much as it is a kind of didactic comedy talking. So these are the interpretive guidance. This is what they say. So when a surveyor would come through and say, oh, this is what you got to look for. Do we have bylaws? Okay. Is the medical staff organized? Does it have an organizational structure to it? That the bylaws apply to everybody. That those say everybody are defined in the category. Medical staff categories. Who knows what category they're in our medical staff right now? So I think our categories right now are active, affiliate, consulting, visiting, proctoring. A couple others, aren't there?
Courtesy.
Emeritus. Honorary. So honorary is another. So folks get assigned, and if there are criteria that exist to say how someone can become a member of the medical staff, those are in the bylaws, and listed in the bylaws as such. And then once again, emphasizing that we're responsible for quality. So I think the question that came up when I was reviewing this was, Tom's going to talk a bit about this. How did we get here? How does it arrive that there's a law out there that says you got to have an organized medical staff, and by the way, medical staff is responsible for quality. We get here.
Well, briefly, it's an evolving story, particularly in the 20th century. If we look back the way hospitals first started, physicians were sort of in charge. It was their clinics; they were in charge of what was going on. And particularly in the late 1800s, you see that. In 1918, the American College of Surgery set minimum standards for healthcare institutions that included surgery, laboratory, radiology, and stuff. As that went on, as they got bigger, superintendents, or what we now call administration, started to come into play in the 1930s to 40s. Because physicians were still, there were other interests involved in hospital care, such as communities. Sisters of Charity, Mary Jo, our librarian, brought that up, that hospitals weren't just founded by physicians back then. As communities needed or saw a need for their area, such as Vassar, started by Vassar Brothers. They weren't docs. So they said, we need a healthcare facility, we would like a healthcare facility for our community. So they started something like this. They're not doctors, they need a medical staff. So the medical staff had to come. And with that, then boards evolved out of that, because if it's a community-based hospital that says, we want this care for our community, it would, the idea was, we have people that are vested in that community, that want an interest to keep their community healthy and safe. So that's how we got sort of into this triumvirate. It's not a triumvirate, really. It's the three different levels of where we function today. So the board is responsible for the overall setup of, the board of trustees, I should say, for the overall setup of hospitals nowadays. Administration got bigger and bigger through time, especially as we evolved into the early 60s, particularly around Medicare, which happened in the mid-60s. There was a whole different payment system that began at that point. So money became tighter, things had to be done in different ways, and at that point, physicians, may have stepped out away a little bit from their activities, in hospital because they were working in their hospital. Yet the hospitals continued to grow. But boards really weren't educated in medicine, the community boards, not community hospitals. So later, in the late 1900s, physicians, became members of the board. The board of trustees became more integrated, and again, ultimately responsible for what care was done in the hospital. But physicians were still going to be the biggest drivers of what goes on. How are we going to take care of patients here, and how are we going to do our best for them? So as they grew, to today's point, we've got large administrations, we've got a board oversight, we've got hospital staffs, which is what we're really going to try to talk about today. In the around 2000, as these entities kind of grew, you started seeing things coming out like, what are we supposed to be doing with these things? There was a white paper about 1999 or 2000 called Crossing the Quality Chasm.
And the first one was to err is human.
To err is human.
Followed by Crossing the Quality Chasm.
And then, in my look, through this stuff, the literature started to become alive with, well, what are we doing? What are we supposed to be doing? This was in the early 2000s, emphasizing quality, putting where is that coming from? Hospitals started to look at stuff that was easy to check, like patient satisfaction. Is your food warm enough? How you were treated and everything like that. Because quality was a difficult thing to measure. We had no concrete way to do it. As electronic medical records started to come around, that was the key that was going to help us try to get that data. But it's still not a perfect thing, and we're not going to really be talking about quality today, but it's going to be who's supposed to be driving that quality. So we've evolved to this point where for at least the last 12 years or so, the look has been hospitals have to demonstrate that they can do quality. And the physicians are really the ones who know what's going on in medicine currently, still could be the best drivers of that quality. And that's kind of where we are now. I think physicians sort of abrogated that responsibility because it became very expensive to run hospitals. And they said, well, we'd like to do this, but we don't have the money to do it. And part of what I see in doing this is to make the medical staff aware of what we can actually be doing, what we should be doing, and what we have to do by law from that previous one. So it's got to be a much more cooperative, engaged, and knowledgeable staff about what our responsibilities are. So that's kind of the history of that.
Questions on that or dialogue on that? I think about it as, there's so many airline analogies to medicine, On the one hand, I like them, but the other hand, I realize the human body is much more infinitely complex than 747. So sometimes the analogies have to stop, but at the same time, the outcome of an airline flight, the quality of the experience, we'll say, the ultimate measure of quality of an airline flight really rests with the plane, the pilots. They're the ones who are the safety officers then in airline organizations. They're the ones who establish the standards for around flying and things like that. So they're responsible for the takeoff and landing. They've got a lot more stake in it than a than sometimes we do in medicine, but patients don't suffer the consequences if we're not fully engaged in quality. But you know, that's, I think when how did we arrive with the pin with the rose that you're responsible for quality? Because as Tom said, we know medicine. We know what a wound is supposed to look like, good and bad. We know what an outcome is supposed to look like that's good, and that's what we're driving for, individually, and then taking a step back at the population. So I think that's, and then that's what this gets to. So that's how I think, you know, we got legislated into that role. Medical staff's responsible for quality. Because in many ways, you know, we previously owned it in the development of the health systems in the hospital, and that this now compels a level of standardization, you know, across the country through, you know, the PMS. And so, okay, you got to have a medical staff, and it's got to have these things. Okay, and some of the things that it's got to have. This one's for Bob. I love this one. So Bob, this is for you, Bob. Must be organized and accountable to the governing body. Previously it said responsible for quality, but now we're also accountable to the governing body. Not just responsible, now accountable. Two different words. We have to have some bylaws. So we can have an executive committee. And if we have an executive committee, that has to be mostly doctors, osteopathy or medicine. And then we got to elect someone to run the show. Bob. That's Bob. Law says that. And that then places responsibility for how we do health care and how we do quality on the medical staff under the direction of the medical staff president. Did you know that, Bob?
Not until I was already here.
Yeah. And again, this is why, you know, we have to be aware of this and learn this. That's where we go with that. Even more clear. It's not enough to say it once. It wants to say it again. Emphasize. Medical staff must select one person. One. Must select one.
It doesn't sound like it's as much fun as they said it would be.
These are our bylaws, or these are bylaws in general for any medical?
This is conditions of participation for medical. So we want to, you know, and that's what I say, so the history of how we got here, just standardize, it's a forcing function across the country to get to some standards and say, hey, we're going to drive quality, and one of those elements is that, you know, we have to have a medical staff, it's got a president, it's got bylaws. Okay? So, that's just
The whole idea that the medical staff is responsible for quality, I think, now is a little archaic. The medical staff, you know, maybe from the time when hospitals were started by doctors and owned by doctors, which they're not anymore. I mean, I think it's interesting that we're responsible for quality, but we don't run the corporation.
Right, and that's a very good point.
But that's true, and I think that's why you'll see this big transition. I have a couple of things that I don't have enough for everybody. A couple of things that I put out, looking at the structure of the medical staff, kind of where it was and where we're going, you know, in the 21st century, and with every referral, you can look at the whole thing online. But I mean, speaking personally from where I am, you know, I'm an outpatient sort of person, so I expect the hospital's here to take, you know, so I can use it and use its consultants and its services. But the way it's got to be set up, again, I think physicians drifted away, and that's what you can see in the mid-'60s. We drifted away from that responsibility. We're never supposed to really give it up. But you said, well, everybody's out working in their office, you know, so I can make more money in my office than I can here. So we stopped being part of the hospital. And we really shouldn't do that, because there are the board members, you know, I don't know if you've ever had a chance to talk with the board of trustees. There are a lot of very interested board members, you know, here that want to know more about what we go on, but they really don't. And just as a aside, recommendations for boards of trustees today include a lot of hours, a lot of CME in learning the medicine side of things, not just the financial side of it. So they're being pushed to understand what we do in the hospital. We're trying to be pushed to say, listen, we can ensure you that this hospital that you have for our community, we're going to do a good job with the people that come here. And that's really the medical staff's responsibility. And that goes back, how do we set ourselves up? How do we make this a good place, you know, so that we can say to the board, you know, and the administration, we're doing our job, you know, because we know it, we really do know it best. I don't expect administration to know what, you know, I do or go do a colonoscopy or something like that. So we need to say what the standards are. And I think that's why we still have to be the drivers of quality. And I have a nice little quote at the end of this paper for you, whether you like it or not. You know, that's what we have to do.
And there's a creative tension around that, and we'll get to that. And that's the organizational structure we'll get into in a moment. But I think that, yeah, this drive, and to err is human, and crossing the quality counts of two papers by the Institute of Medicine that came out about 15 years ago now, began to address that divide that exists between, you know, what is quality, what are outcomes, in a fee-for-service economy. You know, and we've all seen the literature and we've read the reports about how, you know, we have the highest healthcare costs in the world, we don't have outcomes that are commensurate with it, and what does all that mean? And some could argue that it's because of this, you guys go off and do the doctoring stuff, generate the RVUs, we, the hospital, will manage the business. Okay, and that break has created a scene through which quality can be missed. And part of this then, in the literature of late, Tom's referencing some of it, and it comes back to structure, organization, is to bring that back and to get physicians, again, emphasizing physicians are responsible. Okay, so you're not responsible, so you got to do this. You know, back at the table and saying, this is what quality is. Now, again, quality is a huge amorphous blob, it's a large amoeba, and each of us say it, we've got different ideas for what that means. And time for later discussion, but at least owning that is, I think, part of what this governance structure says. So this is largely how we're organized here. Think of this as perhaps one of those subway maps. You know, it kind of tells you where you are in the city, but it's not really a scale map of the city. You know, but you know if you follow the green line, you'll get where you want to go, and there's an intersection with the red line that'll take you up. So, but the representative of what our bylaws say and what our hospital bylaws say, we're organized. And it starts with that governing body. Tom's talked about the governing body. It's responsible, and that's community members. We are a not-for-profit or non-profit hospital, okay? A way of thinking of that in terms of what non-profit means is that we're owned by the community. Our stakeholders, our shareholders, if you will, are the community. And we're not a privately held, we're not a publicly traded corporation. So we're responsive to the community and the needs of the community. The governing board is what says that. It says, okay, well, these are the needs. This is how we want the hospital to function. We want us to be this. And how do they get to that? Well, there's those two arms there. One, as you see on the administrative side, you've got the president of the hospital and all the underlings there. Okay, and
I have a question.
go ahead.
Who appoints or elects the lay members of the board of trustees?
The board of trustees does. Okay, so it's done by the board of
So it
trustees. Yeah, in consultation with board members and community. Bob, and can you comment? You went through that.
There's a nominating committee,
Yeah.
and, you know, they ask for recommendations, and there's an outreach to individuals, and they're vetted and interviewed.
So are most of them like business leaders in the community? Are they very philanthropic towards the hospital previously?
Well, there's no specific criteria. There is a emphasis to try to have someone that's involved in medicine in some way, shape, or form. There's also economic imperative, things of that nature in general. But they're usually community leaders that are known by prior board members.
Yeah, so I think maybe our board right now is composed of, we've got insurance executives, we've got banking executives, Carlos with IBM for a number of years,
couple
IBMs, corporate leaders, and then just as well as members who are active in the community, either through just work. Our current board chair, Francoise, is a former nurse. Okay, so I mean, I know she's a nurse here, but she's has nursing experience. So, but yeah, nominated by the nominating committee. Questions about that? So that's our governing board. Probably good if I think about how I do this presentation, we should have a picture of the governing board, or maybe include that in the slide. I'll keep that in mind. Who our governing board is? That would be good to add. So
And their term is for how long?
3 years,
Yeah.
3. Like in St. Luke's, I know it was 7 years, so some boards go very
They can
long.
be re-elected or reappointed.
Right, and usually a third rotates off every year, so that you have long continuity, within the board.
And I think, they are, as Bob said, they're interviewed and really sort of vetted, and they have to be a fit for the board. They're not just looking for cronies to come along. In my interactions with board, members in the past, they do tend to be very interested in what goes on here. They're very, very interested in how we do things well here. And again, their requirements are even growing. A lot of the recommended requirements about understanding medicine is even growing more. So their job is getting tougher too, just like ours is going to be, as we address how, our quality again. But that's not for us quite today.
Is there any money involved? Like, do they get paid to do that, or do they have to make a big donation in order to do it, or is there?
No.
So if they're non-paid positions, they're volunteer. I don't know that some are donors, but not necessarily all are. Okay.
And we do have a mix. There are physicians on the board too, it's the new laws, the new revised laws say we don't have to have physicians on the board of trustees, but they have to meet with the president of the medical staff at least twice a year. Our board still has physicians on it. So during those meetings, there is direct input by physicians, to the board of trustees, and the trustee members are actually sitting on some of our functioning committees now. So they are getting a more inside view of what we go on. And I think that's, been very helpful. At least the feedback from the board members have said that's a good thing. And they ask questions that are slightly different than a medicine brain maybe would, which is also very good because it makes you stop for a minute and think from that. So that's why I think keeping that collaborative channel open is best for everybody, because you'll start to learn things that you didn't quite think about,
So in our bylaws, I keep coming back to this, because we're supposed to have bylaws. Okay, now, CMS doesn't say what our bylaws have to include other than a couple things. I'll get to that in a moment. But it says we have to have an organized medical staff, and it leaves it up to how we want to organize that. So we organize ours by department, all right? We've got a lot of departments. Okay, Department of Anesthesia, Emergency Medicine, Dentistry, Family Medicine, Medical Imaging, Radiation Oncology, Surgery, OBGYN, Orthopedics, Podiatry. It's a lot, okay? And each of those departments has a department director and an assistant director. Departments may be subdivided into divisions, and the division directors have responsibilities very similar to the department directors. And department directors recommend privileging, review the privileging files, they convene meetings and report to the MEC, they sit on the medical executive committee. Functions of the department are also spelled out within our bylaws, and significant among those are that, supervise the quality of our providers. Okay, one of the stipulations in there is that every department will have a medical audit committee to review cases. Will establish standards for, the department members to follow and to adhere to, and then we'll survey that to see that we're meeting those standards. So that's all spelled out, in our trustee bylaws. The bylaws also establish committees, all right? This version, the current version of the bylaws, lists a number of committees, some of which are appropriately medical staff committees. And by medical staff, I mean committees that do the business of the medical staff, credentialing. That's a medical staff, that's only something we can do, all right, that's it. Impaired provider committee, again, only something really we can do. Executive committee, bylaws committee, those are the big ones that are, that are really medical staff committees. The current bylaws also then go on and task the medical staff with a number of other committees that are more hospital committees, such as pharmacy and therapeutics, utilization management, infection control, laboratory improvement. There are a number of that very important to have medical staff representation on, but in the new version of the bylaws, we've moved those out of the medical staff and put that back on the hospital. do that. But again, that's part of how, you know, we then, we're responsible for quality, okay? We have to be participants in these committees and to ensure that the quality side of it, you know, the outcome side, the patient care needs are met. Right next door, the Pharmacy and Therapeutics Committee is meeting. And every month they meet, they're considering a new medication, a new therapeutic that we think, or some member of the medical staff thinks is important for the quality of our healthcare. And that's what they do. And then they review the data and say that, you know, is this as safe as we think it is? And are we getting the outcomes that we're supposed to be getting for these medications? And that gets reported every month to the Medical Executive Committee. Those minutes then go up to the governing board. So again, that's showing that accountability piece that, you know, we're doing it, and the importance of having physicians saying, hey, you know, I've been reading the literature, and this is a very good medicine that I think we need to have here. Okay, well, prove it. We have to have the prove it part, you know, and that's well documented in minutes. So I think this committee structure, as well as the department structure, start to tell us in our governance how it is we're responsible for and how we are accountable for quality. Does that make sense? Questions on that? And this was something you were talking about. This is a great idea.
Yeah, this, I think this is a really important note to take away here, you know, that to have an effective system, you know, if you look at highly performing hospitals versus middle of the road and poor performing hospitals, you know, going back 10 years or more, it's when their boards were really looking at quality stuff, not just the temperature of your food and did you meet, you know, your finances and stuff. So again, that's why, you know, if we want to be a high quality, you know, high functioning hospital, we need to do, you know, more in the way of quality. It's going to be defined somewhere along the way. But the way we're supposed to be working, as this slide says, it's a system of checks and balances. It really is a government type of thing that we need to be able to feel that we can present things to the board. Obviously, they should be correct, you know, data back, and get that cooperative measure going, I think, better. I don't know, and I'd like to take a straw poll of people who've been here for a while and see what they feel their voice is to the administration, but we don't do that today. But each one of them, the Board of Trustees, the medical staff, you know, and the administration, each have their own areas of authority and power, and we have to be able to speak to them, you know, in a civil manner to try to get these things fixed. For our part, you know, the tools that we have to do it are going to be credentialing. You know, we're going to be responsible for admitting or allowing other physicians and care providers onto the staff, and increasingly that's going to be also quality driven. You know, right now I don't think we have enough quality data to credential people that way, but that's got to come. Everybody's got to do that. We also have, it was in existence for a while, does everybody know the FPPEs and the OPPEs? Have you talked about them at all?
Focused professional practice evaluation and ongoing professional practice evaluation.
Everybody heard of them? Anybody ever have an audit or a sit down?
Peer review. Right. Probably everybody's heard that.
So peer review, but this is something also set down by law that has to be, you know, hospitals have to provide it. And I mean, they exist. I don't think we use them to our maximum effect yet, but that's because I think they're ill-defined. And that's our job, is to define when we get a new practitioner on the staff, are they keeping up to speed, you know, with what we expect as a participant of this medical staff. And the same for our re-credentialing. The ongoing professional practice evaluation is what we have to be going through every time we're re-credentialed. You know, so these are things that it's our responsibility to set those standards in each department, and each department has really got to figure out what do they want to follow. And so that's going to help us measure that we're doing the job we're supposed to be doing. And then peer review just is peer review. That goes through the medical audit committees, you know. But those are our jobs. They are not part of the administration. I think my outlook is that the administration is going to give us the tools, to do that, which historically, it was very difficult to do. The EMRs are supposed to make it easier. We just have to figure out how to work the EMRs to do it. And that's true across the country, I think. Right? So those are our responsibilities within this working body, to try to get to a collaborative step.
I think that system of checks and balances and the thought of it, I really think is fairly elegant. It was interesting to read that in the legislation itself, because it creates this system of checks and balances where, we're the advocate, accountable for, responsible for quality, and we have to have that voice at the seat at the table. We created structures around having a seat at the table, literally and figuratively, but at the same time, there's going to be a dialogue. There's going to be conflict over priorities. And how do we balance that? And how do we ensure that, the patient is kept in the center of that? Not in the center of the conflict, but the focus of, often the center of the conflict. No, but often the focus of, hey, why are we doing this? And I think there's a great view of that. So I'd like to read in that. So just a blurb about the MEC, this next slide. Why don't you read that for a moment? Still emphasizes, the role of the physician. Okay? Doesn't say it's exclusively physicians. Just the MEC must be composed of a majority of physicians. So it recognizes that we have a health staff that has inequality as part of a larger community of providers within a hospital. Okay? But it's still driven by the physicians. So we've been talking about quality, so accountability. Yeah, all right. Yeah, so accountability of the medical staff. I should read the slide faster than I can read too. So Tom was speaking to this a moment ago, in terms of the privileging, credentialing process, peer review, focused professional practice evaluation, ongoing professional practice evaluation. That this is what we do. The last line, again, emphasis on mine. I put the acknowledge, wasn't in the law this way, but just to read that. In implementation, leadership participation in the organization and implementation of the hospital's quality assessment performance improvement program. This is why you're here. I don't think anybody's here saying, I don't want to be part of quality. I know, Jill, you're on the EDPI committee. Not EDPI. But it's not just being in the PI committee, it's being involved in performance improvement initiatives. Most of you have participated in that. Sat at the table, gone to department meetings or multidisciplinary or interdisciplinary meetings. Saying, hey, this is my opinion. This is what my society, this is what my special review, this is what the guidelines say. This is why we have to move it in this direction. You're the subject matter experts on this, and it's informing a broader audience. That last line, quality assurance, performance improvement. Talk a bit about that, okay? This is a slide that gets to that. So I mentioned at the outset that CMS is coming to take a look at us. And they're coming to take a look at us in part because we were not able to speak to how data, quality data on our programs, information, informs the decisions of the board and tells us that we're giving quality health care. So this is the structure that our bylaws and hospital bylaws say we have, and we've been very busy over the past couple months going around and making sure this is what we're doing, and in some places we're doing it very well, in some places it needs some shoring up. But this speaks to, at the department level, the quality department gives the department director, Dr. Spirit can tell you all about these stacks of ongoing professional practice evaluation, which is trend data, rate data around known events that occur in patient care, surgical site infections, return to OR, morbidity, etc. So we're looking at data every 8 months in every provider. That's OPPE. That goes to the department. Bylaws say that's what we're supposed to do. Our bylaws say every department must have a medical audit committee. It's responsible for doing this peer review, among other things. also supposed to do focused professional practice evaluation, which are rules and regulations. They occur for new providers, newly appointed to the medical staff, 5 cases over the course of 6 months. Focused professional practice evaluation can also occur if concerns arise. So, hey, in response to an OPPE, we have concerns, well, then we might do a focused professional practice evaluation. That's the department director saying, you know, we need a little more of this, okay, in consultation with the president of the medical staff. So that goes to the medical audit committee. What we've also been doing, and our bylaws allude to this, but we think as an organization, more codification around is for identifying things that prompt review. What are those indicators for review? So in addition to doing focused professional practice evaluation, what are those community standard events within particular community providers that prompt us, the medical staff, to look at the care given? Okay, so those are review or occurrence indicators. All right, and we screen Cerner actively for them. They also get reported by providers or by staff, and it goes into a reporting system called MIDAS. And if those hit the review criteria, then the quality department brings that information to the medical audit committee for further review. And the medical audit committee looks at it and says, is standard of care met, not met? If it was met, is it room for improvement? If it wasn't met, was it this provider or was it system? I'm going to give an example of that. Do you mind if I talk about one that came up from Department of Surgery? Just kind of, because I want to create sort of how this should flow in an ideal situation. So there was one in Department of Surgery PI about a routine foreign body following a removal of a jejunostomy. And then the routine foreign body, I think there was granuloma and an abscess formation. And so that's why it got up to surgery PI. But in further review and discussion with radiology that placed it, those are the anchoring folks for the jejunostomy. And radiology's been using that for years. So that now prompts us to say, well, how often is this occurring? Okay, let's look stay behind, and radiology says that, well, they either stay behind and it's not a problem or they're passed. Well, here's one where there was a problem. So how often? So now quality has to trend this. How often is that a problem? There wasn't a standard of care wasn't met, but now we've seen that there might be something related to systems. This is a medical staff saying, hey, this shouldn't happen, wounds shouldn't look this way, all right? Could it be related to equipment we're using that we've been using for 10 or 12 years? Is there something better out there? But we need the data to show that. That's what conditions of participation say we're supposed to do. We use data from our quality, these reviews informing it, to now go back and look at these jejunostomy tubes that are being placed and follow them up and see how often are we seeing this particular complication. And that then may inform the systems change to say, is there a better device? That's a very long way of saying, perhaps radiology goes, yeah, we don't like this device and we're going to change it. But at least it's giving an illustration to how this type of review fundamentally gives data to the governing board, which executes that through the CEO and her lane, the president and her lane, to make these changes occur. Does that make sense? So that's what this is showing. All right? Again, one of those subway diagrams. Other committees in the hospital, such as the Critical Case Review Committee or RCAs, may opine that the standard of care wasn't met for systems or raise questions about provider standard of care. That then gets kicked back to the department, because only the medical staff. The medical staff is the one that makes opinions about whether we are giving standard of care. All right, that's our job. And then we report that up through the department or through the PUPIC to the Medical Executive Committee. And that's showing how the reporting and how we're accountable to and responsible to the governing board, the Organization for Quality of Care. That makes sense? So some of you have seen some business around this and we're continuing to do that, but we're working very hard as a medical staff and as a hospital to do this right. That's for patients and CMS is coming. Right. So Tom, further comments about that?
Only, again, if you're like me, you're asking, well, what tools do we have to do that? We don't really have them. And then Mike said, we have to develop them, and there's no other way around it by going forward in medicine today. So that's why the medical staff needs to be aware of that, especially at the department head, how are we gonna start to measure what we do, that we're doing it right? And that is still an ethereal thing. It's not concrete, but we now have the things in place, EMRs make it easier, but we have to figure out what do you put in the EMR, because they're only as good as the data we can get. And I'll just read a little quote from the advisory board, just around this. It says, despite the ongoing controversy around physician performance monitoring and data attribution methodologies, because probably nobody in here believes that data is correct, it is increasingly a fact of life in the healthcare industry. We have to do this. And you know better than I about the oncoming, we've all heard about it, but the oncoming reimbursements for payments are going to be based on. So whether we like it or not, it is something that we're going to have to buy into, and that's why the medical staff, I think, really needs to step up to their place. Let's define what we do well. And the administration, and I certainly think the Board of Trustees is very open to it. We need to have a friendly, can be adversarial dialogue, but we have to come to a common ground. And that's what you see in high-functioning hospitals, is that the administration and the medical staff can work better together.
And the importance of we talk about the billing and the reimbursement, again, we're a nonprofit. So the money that this hospital makes gets reinvested in the community and in the hospital to promote healthcare in the community. It's not going to a mutual fund or a hedge fund, not going to stockholders or shareholders. And so, that's, when we talk about then these reimbursements, so we're on the hook, I think, for 2017, based on data, for about a $900,000 hit for quality measures for Medicare. The bulk of it is patient satisfaction. So we need to do more work around that. But, we lost points for, unfortunately, early elective delivery. Not that you're responsible for early elective delivery. We know we're not supposed to deliver babies before 39 weeks electively, and yet somehow we continue to do that. We lost points around CLABSI and CAUTI. Okay? These are preventable steps. Why are the central lines staying in them? Those kind of questions that we as a medical staff have to answer. And it's, again, not about lining our pockets, but that $900,000 would go a long way to getting a 64-slice spiral CT scan. You don't think that would be useful to have here? 64-slice spiral CT? I'm all about that. So, it just would. And these are things we can fix. So, Tom's reference to the reimbursement and the role that quality plays in that, getting to know that. And Tom and Ryan want to make sure we understand those. That's just a passing reference to that. The financial bottom line is more about quality.
That's not our job. Our job is to make sure that we get things in place so that we can function. Our job is to...
And then the other part about things in place comes back to, and Jill had commented to me earlier, when we talk about doing peer review, what are we looking at? How do I know what I'm supposed to do when I read a chart and I'm asked to say what's standard of care? That's a good question. So we probably come together some medical staff and define that. Are we looking simply at the surgical management of the patient, or are we looking at sepsis that then follow? And do we manage the sepsis appropriately too? Surgery was great, unfortunately the patient got sepsis. Well, okay, sepsis happens, but then did we manage sepsis properly? So those are questions, what are we looking at when we do these reviews? And that's important.
Are there any hospitals that are for profit?
Are there any hospitals that are for profit?
In our area.
In our area? Is HSS, Hospital for Special
I don't
Surgery?
think New York State is.
I don't think they're right. Yeah, New York State is not. That's right.
No hospital in New York State, but Connecticut,
Yeah.
they can have a few for-profit hospitals.
Not in
Not in New York.
So now I mentioned earlier that there were some 300-mile screwdrivers from DC telling us what our bylaws have to have. You've got to do this. Okay, and these are a couple of the elements. That's not many. That's really not. Because they have to be approved by the governing body. I think it's very important to understand that it doesn't say the hospital bylaws must be written by the governing body. So who owns the responsibility for writing bylaws? We do. Okay, we are self-governing organization that's separate from checks and balances, the hospital administration responsible to the governing body, responsible for quality, and accountable to the governing body for it. We say how that gets done. Yeah, there's some things that CMS says we have to have, but these are our bylaws, the medical staff. And then a couple others. Yeah, I mentioned it, tells who can be on the medical staff and what the prerogatives are. So in ours, if you're active, you get to vote. But if you're visiting staff, you don't necessarily get to vote. You know, things like that. Tells you what the criteria of member, or what the categories of membership are, what the criteria for membership in the medical staff are. You have to say the organizations. It shows you the wire diagram. Ours is the listing. It's a table. Okay, it says we're organized in departments. Here's the list of it. And then, what are the qualifications? Doctor of osteopathy, doctor of medicine, licensed in New York State. So those are those are the qualifications of it. There is a really long slide that I put up there that we've all seen it. That tells you have to have an H&P on the chart. Then 24 hours. We're done 30 days before, but if done 30 days before, it has to be updated within 24 hours. It's not one of ours. That's why it's in our bylaws, and it's almost verbatim for what CMS requires when you read it. That's, again, a 300-mile screwdriver. But obviously they're telling us to do it because people weren't doing that. Many of my patients were in the hospital. So they felt the need to standardize that and say, you got to say why the patient's here. What's your plan? So, I think that gets me to my last slide. Really? Really? Okay, so let me ask this. So here's your quiz. Here's your quiz. So, what are the mechanisms by which the medical staff fulfills its responsibility to be accountable for the quality of medical care in the hospital? A mechanism. What do we do? How do we do that? You don't get CME if you don't answer it right. Okay, fill in the dot. AAA. QI committee, so doing the peer review, medical audit committee, so showing that, we're looking at it. Okay, that's one. Yep. Credentialing, responsible for credentialing, looking at the providers, ensuring that folks who meet the qualifications are the ones applying, and that they also have the requisite character, competency, training, education. There's a few things that do get listed out that are necessary to be a member of the medical staff.
Hospital committee would?
Participate. The leadership participation in the quality improvement activity. Okay, which isn't just doing chart review, it's using that experience you have of working in the hospital to know where we need to improve, and then being part of that guiding the solution towards improvement because you know what the outcome is supposed to look like. Other thoughts? Yeah, I kind of tied to this question one. What are our medical staff duties now that we perform them? Question one of them, you're here. You're saying, I want to be a part of this. I'm interested in knowing and doing the work. Just because you're here, you're not volunteering for anything, just so you know that. Not on the mailing list now. Oh, it's at the committee. You're going to be on this committee. No. But I think by being here, you're saying I'm interested in how this work gets done. If there's an opportunity, count me in. And so, you are on my short list. Would you like to be a part of the committee? And actually, it's Bob on the point of the committee. Remember, according to Bob. Bob, not me.
Every single unit?
All of them.
Every single one?
Awesome.
And another new one, like we've had a couple of new programs coming here. So as we get new technologies, new things that come in, TAVR being one of them, it's our responsibility to set down what is acceptable, here. We have to do the delineation of privileges for it, describe what the thing is, what your qualifications are going to have to do. And, as we get faced with new things, which we have been, we don't have any policies for it. So it's our responsibility, the medical staff, particularly medical directors, to sit down and flesh some of this stuff out. And, that goes through credentialing and other. But that's going to be a big one for us. I think as technology advances and we don't have, there's nothing that says we know how to do this stuff.
So just to give you an idea on how that's done is that just to do one TAVR case, the patient has to be seen by two independent surgeons separately who have to decide that the patient is not an operable candidate. Then has to be seen by the cardiologist. Then it has to be, have a multidisciplinary meeting once every 2 weeks, and we discuss whether that patient is appropriate. Then we get them worked up, then it's done by a cardiologist and a cardiac surgeon. And then after it's done, we have a post-mortem meeting for ongoing review. Every case.
Hopefully not.
Not post-mortem, what I mean, procedure. What I meant was that post-mortem means that we go through the
Yeah,
whole
sure.
process all over again for every patient.
Right, so that's how you're gonna go after the quality, but
That's
before we even do anything like that,
Exactly.
the medical staff has to set up, how do we do that in this institution? Because we've never been there before. And so that's a big, huge responsibility, now, and I know that Ryan did a lot of work on the TAVR, delineation of privileges, before that. So that's something we're gonna be working on, I think, quite a bit in the future.
That's just one example, one program. So think of the breadth of programs here and how the tremendous amount of work that involves. So the last question entertains some answers too, but I'll close out with some of my thoughts on it that, I'm sure Bob and Tom will share because of our experiences with Greeley. But how do we demonstrate this accountability? How do we show that we're accountable?
Well, I mean, hopefully our behavior rubs off on other people who don't behave so well. I mean, that's a big thing. I think physician behavior, we all know docs that do things differently than I think we would think they've been done. And, as certain behaviors are propagated, everybody else thinks that's normal behavior. And I do think that we have to look differently at how we behave in the hospital.
I also wonder why there's no requirement for attendance at medical staff meetings and I've never been in a hospital that didn't have a minimum requirement.
Well, there is, but I don't think.
It hasn't been reinforced as a requirement, and by the way, thank you for mentioning that. The next general medical staff meeting is July 13th, and we are going to be approving those bylaws. So if everybody please come and
So we have copies of for
ask all your
sharing.
counterparts to come too, please.
So I'm glad you brought that up because Bob's tired of hearing it. But I think that goes back to how we got here. It goes back to our question before. People have just drifted away from participating in hospital. In the mid-'80s, the meetings were full, here. But they don't. People aren't interested. And is it because we as a staff don't work well together? Is it because of distrust of administration? I think those have to go by the wayside because if we want to move forward the way we have to, by law, and I think the way we should, we have to reopen the dialogue between physicians themselves and the administration. But in my personal feeling is that the Board of Trustees is definitely on, well, it's on both sides really, but I think we have a good Board of Trustees right now. So the three.
It's also more of a petitioning of physicians into outpatient and rehabilitation, and I think that the physicians that only do outpatient almost feel disenfranchised from what goes on in the hospital. And partly that's their own fault, and partly it's the hospital side's fault. But, we never admit a patient to the hospital anymore because the hospital doesn't take care of them. We're just so, separate from the hospital that it just becomes more difficult to participate. So we have to think ways to encourage people to participate.
And I agree with you on that, but there are physicians who have chosen not to be part of the hospital anymore, and that's they won't let the hospitals take it. But there are others who have not, and I think that's what we have to take and build on. Everybody who is interested in doing something here, it'd be nice to be able to have physicians speak a little bit more. I think we can disagree with administration, but it's not like they're wrong, forget it. And I've seen that attitude, a lot of times. It doesn't make any difference, what we say, the administration's wrong. And that's not the way we're going to go forward. So.
Yeah, I think what Bill said, I think, especially within our department, the attendance at our department meetings is great and very robust. I just think that people are very vocally identifying issues, but they see it as, well, they're the community pediatrician, and they don't have any stake in being able to affect change in the hospital, especially now that we are using a hospitalist service. So their participation in patient care, other than the nursery, is really limited in the, I send the patients to the hospital and they come back to me and I can fume about what happened while they were there, but then they don't take that next step of helping to improve things so that they are, that the quality improves and so they feel more invested. I think that's the struggle, at least in my department, that I think we're having.
I think that the movement towards, integrated, delivery systems, community-based integrated delivery systems will help change that, remove some of the estrangement or the alienation that you're talking about, because it compels us to work more together and see, the continuity of care that exists, from the community to the hospital to post-acute care. But when it's a fee-for-service economy, each one of these discrete episodes, it's very hard to recognize how tied together we are, because we're not.
Right. Even just saying, like, for our QI committee, and, we have all these charts to go through, and I said, well, even though we don't have, grand rounds over the summer, and said, how about we all commit an hour a month to just come in, that's what we're spending anyway, and we'll just do it through the summer too. And everyone looked at me like I had a third eye when I said that. And so I think, how do we change that culture of this divide of community outpatient and investment in the community hospital?
So the American Hospital Association, it was late 14, early 15, had a bit on just the identity crisis of hospitals. Inpatient admissions would decline, outpatient procedures, outpatient surgery centers, all the other things that were, for the past 100 years, up until the late 20th century, were very hospital-centric, no longer are. So what is the role of the hospital? I can tell you, just from my experience in Afghanistan, you don't need a hospital to have an ICU. You can have a hospital in a trailer in a gravel parking lot. Okay, you really can. Same with an OR. You don't need this building to provide that level of care. Okay, sometimes economical to do that, but it's not necessary. And so, and that's pervasive throughout it. And we get to this dynamic of, I don't need the hospital when you're a community physician. I don't need the hospital, And how do we then increase the relevance? And that's a challenge. It really is. And that's culture. And so the accountable part, and how are we, accountable? When we look at it, and Greeley speaks of it. They talk about this Greeley pyramid. And it starts with, establishing their conditions for being part of the medical staff. What are those conditions? What are those requirements? And then the next level speaks to, well, okay, let's maintain that. Let's provide feedback to how you're doing regularly. Both good and bad. You don't just call folks jobs and say, hey, you're not doing well. You celebrate the folks that are doing well. Okay, you provide feedback. Now, for the folks who continue to not do well, then you have some more focused work with that. Okay? And then you have to make the harder steps. That's accountability of, all right, maybe this is someone who's at risk for early departure, and then the final step of this is someone who's not really meeting the criteria that the qualities we expect from a member of the medical staff. And that's, but that accountability piece really begins with, okay, policing ourselves at lower level, establishing a culture. And you do that well, you don't get to the tip of the pyramid, which is, I think, an interesting conceptualization. So, what we saw. You can't find the pyramid. The Greeley pyramid is beautiful. So that's really all I had for mine. I don't know, Tom, did you have?
No, I don't think so. I would just ask that if you know people that don't really understand where we are, what we're doing here, in your departments and stuff, I know Bob is pretty open to that. I would like to see, one of the reasons that I'm doing this is I would like to see this medical staff come together and get to the point that they talk about, get to the point where we have high-functioning hospitals. So that's all I have to say. I do have, if you're interested, I have a couple of references, just an interesting article I saw, and this is again from the early 2000s, so they're actually talking about physician structure, physicians driving the quality back in the 2000s. So this isn't just something that's new. It's that transition from around the late 1990s, and it just has a little reference. It's just a good article. I think it'd be interesting to just read. So I have a few little copies of it.
Let me go back to the attendance requirement before the meetings. Part of organization, part of the problem that's the way practication of specializing, not specializing in general surgery department that's more special remember getting letters, I don't know where they came from the uniform administration or BCNA, that you are not attending 50% of the number of staff meetings, please attend. People try to respond to that, you know, people never showed up, they actually didn't show up the last two times of the month or whatever quarter that means. So, and what you do then, if you don't show up, frankly, that's just like, you know, where do you go with this, to give accountability, the conversation, and get that, you know, elevated to writing, letter, et cetera. But again, I think it does begin with setting the culture of what the expectation is, that at least starting the conversation, yes, you're expected to do that, and if you don't do it, at least you hear from somebody. I think that is, right now, I think we're really at the level of nobody cares anyway, nobody loves it. No, well, nobody really says anything, so, I mean, if you want to be on the radar, you have every opportunity to be on the radar, and there's nothing anybody really can do about it. So I think it's important to reinvigorate that process in a way, because I think it's, no, we're not going to be perfect, but I think making efforts towards that, I think will go a long way to creating an engaged medical staff. That helps, you know, quality, frankly. That's what it really shows at the end of the day, I think, the engaged medical staff.
So are, Bob, any closing thoughts?
Pardon?
Closing thoughts?
No, I mean, in case, you know, as you're leaving the meeting, you wonder, well, what was I here for anyway? And it's just an introduction and trying a explanation of kind of the evolving requirements that we have as a medical staff, and hoping that, you know, people will want to get more involved and participate in this stuff, because there are things that have been on the books that haven't really been enforced or pursued, as Tom was saying, and going forward, we're really going to have to do that. So I encourage everybody to, if you want to call me on my cell phone, and I'll find a way to get it to everybody, to just get involved in the committees and things to do. That's all it is.
So our next opportunity will be in July. I don't know the exact date, Michelle can tell us.
15.
And what are we doing in July?
Communication?
Yeah. So just communication skills. So we're doing didactic and then interpersonal stuff as part of the leadership development. The next one is less didactic, more just, you know, how do we work better to communicate? I think we brought that up as an issue. So that'll be our next session. Good. Thank you all for coming. I'm so glad you were here. Other than the slide deck again. Thank you all.
You know, this all, I'm learning a lot. Well, I figure I'm pretty average. Whoever tells you what you're really supposed to do.
So thank you.